OBGYN, and I'm truly honored to serve you as a Master of Ceremony for today's academic forum. And on behalf organizing committee, we would like to express our sincere gratitude to all of the distinguished speaker, moderator, participant, and also the college from various institutions and also all the countries who have joined us in this afternoon via Zoom webinar and also YouTube channel. And ladies and gentlemen, please allow me to acknowledge and warmly greet also to Chairman and Vice Chairman of the Indonesian College of Obstetric and Gynecology, also to our distinguished speaker, moderator, and we are deeply privileged to be joined by outstanding expert and leader in this field of medical education, healthcare system, and obstetric and gynecology. And let me to greet and mention our narasumber, our speakers today. The first one is Dr. Ivan Rizal Sini, GDRM MMIS Franskok SPUG. He is a chairman of the Indonesian College of Obstetric and Gynecology. The second one is Professor Eric W. Driessen, PhD. He is a professor of medical education, Faculty of Health, Medicine, and Life Science, Maastricht University, the Netherlands. And the third speaker is Professor Citra Nurafah Binte Zainematar. She is Associate Professor and Clinical Scientist in Obstetric and Gynecology with expertise in fetal medicine, maternal fetal health, stem cell biology, intrauterine therapy, fetal surgery, and also translational medicine. And also she is a lecturer in health policy and system from Department of Gyn of National University of Singapore. And the fourth is Professor Dr. RRTT Savitri Prihatiningsi, M.Med. ED PhD. She is the professor in Medical Education Faculty of Medicine, Public Health and Nursing Universitas Gajah Mada, UGM Yogyakarta. And also to our respected moderator for today's session, Dr. Hermanto Trijuwono, Specialist Obstetric Gynecology Subspecialist Kedokteran Feto-Maternal. He is the lecturer and faculty member of the Department of Obstetric and Gynecology, Faculty of Medicine of Universitas Erlangga. So thank you very much for all the speakers to be here. And before we begin, kindly allow to several notes that the participant may to remain mute during the webinar session, and also participant can give a question in the end of the session after all of the speakers have completed their presentation. Well, before we start the webinar, to officially commence to the webinar, it's our honor to invite our chairman of the Indonesian College of Obstetric and Gynecology, to Dr. Ivan Rizal Sini. Please, the time is yours.
Thank you, Dr. Nisa. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon to everyone. Thank you very much for the participation of our afternoon, our very exciting and very important meeting for this afternoon. And very good afternoon, good morning to my dear colleague, Professor Eric Driessen from Maastricht University, and Associate Professor Citra Mater from Singapore, Professor Titi Savitri from Universitas Gajah Mada Yogyakarta, and all the participant educators from Indonesia and many other places in the world. So on behalf of the Indonesian College of OBGYN, it is extremely a great honor for me to welcome to you all to this international webinar. And of course, today's discussion comes to a very, very important moment for healthcare education globally and across many countries, including Indonesia. We're facing major challenges, of course, in specialist training, increasing healthcare demands, unequal distribution of specialists, rising expectation for patient safety, concerns about our trainee well-being, and the need for a more accountable and competency-focused education system. For many years, medical training systems have always been measured primarily by time and years spent in the training and duration of rotations and service hours completed. And however, modern healthcare increasingly requires us to move beyond a purely time-based model toward a system that's truly emphasized on the competence, professionalism, patient outcomes, and also lifelong learning. Indonesia currently is undergoing a very important transformation in specialist and subspecialist education. And we are exploring how to strengthen the competency-based educations while ensuring fairness, quality assurance and national accountability, and alignment with international best practices. This transformation cannot be achieved by one institution alone, and it requires collaboration among colleagues, universities, teaching hospitals, professional organization, government, and also educators themselves. So that's why I think today's webinar is going to be very meaningful for us, at least for me. And we're extremely honored to have the distinguished experts from international and national medical education communities who will share perspective from different healthcare systems and educational frameworks. Through this dialogue, and I certainly hope that it would learn from global experience without really, obviously taking advantage of your time, but this is really the time for us to reflect critically to our own current system and also identify the solution for our relevant Indonesian future. I definitely would like to express all my sincere appreciation to all the speakers, moderators, and all the team that has been working so hard to have this webinar happening today. And Indonesian College of OBGYN as an entity of the Indonesian Health Council was given a mandate to improve quality, access, and affordability. And that's why this webinar is very important to share the knowledge, how we're going to improve the education model that we are participating to what the government's already given us mandate to improve this really challenging but very important task for Indonesian healthcare going forward. So I hope today's webinar will be very inspiring open dialogue, and this will be also a constructive collaboration and innovative thinking as we work together toward a more equitable and also competency-based and sustainable specialist training system. So again, I want to congratulate everyone for our contribution, and thank you very much. Billahi taufiq walhidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Ivanzini, for the insightful opening remarks, and may your message emphasize the importance of the continuously advancing specialist medical education toward this competence-driven, patient-centered, and globally adaptive system. Well, ladies and gentlemen, we will now proceed to the main scientific session today's webinar. And to get us through this important academic discussion, it's my pleasure to hand over the session to our respected moderator, to Dr. Hermanto Trijuwono, Specialist Obstetric Gynecology Subspecialist Kedokteran Fetal Maternal. Without further ado, Dr. Hermanto, the floor is yours.
Yeah, thank you. Assalamualaikum warahmatullahi wabarakatuh. It is a great honor for me to be your moderators, and in my opinion, I will emphasize what our chairman has mentioned, that it is very important at this time to move from time-based to competency-based. And we have 4 speakers. I personally divided into first with medical education background, and the secondly is OBGYN experience from Singapore and Indonesia. Without further ado, please, Prof. Eric, deliver your presentation for 25 minutes. Thank you.
Thank you very much, Dr. Hermanto. Selamat siang dari Utrecht. Di sini masih pagi. Shall I share my screen?
Not yet.
And the PowerPoint share.
Yes, okay.
Yes, does it work?
Yes, not yet slideshow.
And now?
Yeah.
Yes.
Okay.
Can you see it?
Yes,
Good.
Yes, clearly.
Yes.
Okay. So, my name is Eric Riesen. I have been trained as an educational scientist in Amsterdam, and in 1994, so a long time ago, I moved to Maastricht to as an assessment specialist, and over the years I've studied competency-based medical education. I've designed it, I've implemented it, I've made a lot of mistakes. I also did some things went well. So I want to share, that gave a lot of experience. And I want to share some of those lessons with you today. Ooh. I've also worked with obstetrics and gynecology in the Netherlands when they implemented CBME. That was, I think, almost 20 years ago. So I will use examples. Now, the title is Time is not a proxy for competence, ? And I have added a subtitle, The Why, What and How of Competency-Based Medical Education. Okay. The why of competency-based medical education. Why have we had this modernization of postgraduate training? I think that's something that's done worldwide. And one of the important initiatives that started this movement is the patient safety movement. And that was, I think, somewhere around the turn of the century. And that was there was a lot of attention to prevent deaths in healthcare that could be have been prevented if we had better healthcare. For example, in the Netherlands, there was big in the news around that time that every year a whole Boeing 747 of babies dies in the Netherlands during delivery that could have been prevented. And that, was all over in the newspapers, on the television, on the internet, that it shouldn't be, that this should be prevented. And it was not only about obstetric gynecology, but all kinds of, there's a lot of attention for patient safety in healthcare. And then at the same time, there was research that informed us that during medical training and postgraduate training, the focus is often not on medical matters only. There's no attention whatever given to communication. This is a study by a colleague of me, Valerie van der Eertweg, and she asked the question, very simple questions. How do trainees learn to communicate with patients, with each other, with other health professionals during their postgraduate training? And she compared surgeons with family doctors. And what she saw, that in family medicine, every day this communication was discussed. In surgery, it was never ever discussed. They went 1 week on a boot camp outside the hospital, and there they trained communication, but in their normal training, everyday training in these 6 years, there was no attention at all of how to communicate. The focus was on medical matters only. This is one of the quotes of one of the trainees. It's in our hospital in Maastricht. And we know that a lot of things that go wrong in healthcare have to do with communication, collaboration, professional behavior, things like that. So this worried a lot of people. So what happened was that there were competencies, outcomes, frameworks developed. I think you are all familiar with these frameworks. And what they all have, these are two, one from the Canada, we use the CanMeds in the Netherlands, and then you have the ACGME from the United States, and the GMC has in the UK also has their outcomes. What they have in common, all those outcomes, that they have, they put emphasis that becoming an obstetric gynecologist is more than being a medical expert. You need also to learn how to collaborate, how to communicate, things like that. So that I always call them, when I am on the market, I say to the seller of the fruit, or I say, my specialty is soft skills. These are about the more soft skills, and these are important. Okay. So these are the development, that there was emphasis from society on patient safety. There was a lot of evidence that the more soft skills weren't were paid less attention to than the more medical expertise, and this made what we call competency-based medical education. So now, what is competency-based medical education, and what is the difference with our the way we did it for many decades? Now, I have some characteristics. So one is, and that's already in the title, and Dr. Ivan and Dr. Hermanto also emphasize this. The big difference is traditional education is time-based. So you do an internship or traineeship of 2 months, and then you are expected that you are able to do something. And outcomes-based education says, okay, an outcome is that you can do a normal delivery, and some people that will take 2 months, and for other people it will take more than a year. I think 2 months, nobody can learn a normal delivery in 2 months, but for some people it take a year, and for other people it will take 1.5 years. So you can't say competence is the same as time spent. Some people learn faster, some people learn slower. Also, maybe in Surabaya, when you get a lot of opportunities to practice normal deliveries, and maybe at another hospital, I had the pleasure to be in Bogor in the month of April, and to visit some of the health care centers. And maybe in Bogor, when you are there, you spend your time on other things than doing normal delivery. So there are differences in how people learn, their learning curves, but there are also differences in the possibilities in the workplace. And also so that makes that you can't say everybody will learn. I take now a normal delivery, because that every obstetrics gynecologist trainee have to learn that. So that's an outcome, and the time differs to learning. So an implication, if you say it's not time-based but outcome-based, is that you need what I call vertical integration or longitudinal learning lines. Let's take, for example, Bogor, because I've recently been there. So if you have a traineeship with one hospital or healthcare center, and then I don't know if that's the case in Indonesia or in Bogor, and then you move maybe one in the hospital in the city, a city hospital, and then you move to another traineeship, maybe in a smaller city in the neighborhood of Bogor. What's important that the feedback and the information about how you do normal deliveries is continuous, that it doesn't stop. It's not when you are with Dr. Ivan in his hospital and in this department that you work, and then when you move to Dr., for example, Hermanto, that you have to start at scratch. The idea is that you work continuously towards these outcomes, and that you continuously get feedback, and that there's information in a kind of portfolio or in a dashboard in which the program director gets an idea how you develop for that outcome. So instead, an implication of that is that instead of course and that, you do a traineeship and you end that maybe with an oral examination or whatever, is that there's a continuous learning and feedback. So that all the I don't know how many years a traineeship is in Indonesia. Let's say 5 years for obstetrics gynecology. Is that correct? 5 years? Yes. Okay. So yes, that you during those 5 years get feedback how you do a normal delivery, how you communicate, for example, to if there are midwives or nurses or to the the parents or the future parents, things like that, that there through your whole traineeship you get feedback, and that there's information about what you do well and what you should improve. That's the idea. So the idea is that instead of doing an examination, so taking a hurdle, when you've passed it, there's no attention more. That's what we know normal. Eh? You do a course, a test, and then it's over. You get a kind of certificate, done, no more attention. Now the idea is that continuously you work with patients, and there's a teacher or has somebody from the faculty that gives you feedback and assesses you, and gives you also instruction, of course. That's the idea, and that doesn't stop after 2 months, but that the whole 5 years there's attention for how you collaborate, how you approach patients, how you work with patients, things like that. Okay. Then another, and this is difference is the way I was trained in the 80s and 90s, it was teacher-centered. You know, the teacher decides what you're going to work on. He, often it wasn't he, of course. Most of my teachers were males. And what is in the idea in competency-based medical education is that it's learner-centered, so that the learner comes on Monday, for example, to your ward and said, Dr. Ivan, sorry that I take you as an example, Dr. Ivan, but I've met you, so I know you, so that's more easy for me. Dr. Ivan, we're gonna do this more complicated, I will take a delivery for, again, this complicated, another example. For me, it's the first time that I will do a fertility procedure with this couple, and can you please give me feedback on how I communicate with people that are maybe very stressed, and can you give me feedback, because I know when patients are really stressed, that I'm not always that clear, and that I'm not that good in reassuring patients. So that's what we call learner-centered. Yes. And that's a difference. So in the competency-based frameworks, learners drive their own educational process, and both learners and teachers share the responsibility for the path and content of the learning. So we put more responsibility in the hands of the learner, but that doesn't mean that there's no responsibility for the teacher. Let's take the fertility procedure as an example. If I make mistakes or can do things better, then it's of course the responsibility of the teacher to intervene and to instruct and the learner. Okay. So there in competency-based medical education, the idea is that learners, trainers work closely together during patient care. Of course, in practice, our trainees will often also work independently without that's one of the teachers, clinical teachers is there. But the idea is that at certain moments, the teacher observes the trainee and provides feedbacks and assesses them. Okay, this was the what of competency-based education. So to summarize, it's outcome-based instead of time-based. It is continuous professional development, continuous development instead of courses and tests, and it is student-centered competency-based medical education. Now the how of competency-based medical education. And so the how of competency-based medical education in Indonesia. And so what has been done, it's that you have outcomes and you work towards outcomes. There are initiatives for providing feedback to the trainees, for observation, for assessment at the workplace. And what is expected is that the trainee is more responsible and directs their own learning. So that's the theory, but practice can be very different. Let's be honest. What I told you, I've developed and implemented and studied the past 26 years competency-based medical education. And some things that are work well on paper don't work quite differently in practice. So we have learned a lot of lessons the past 26 years of what works and what works not. And this is a paper from two of my colleagues, Ollen de Kaat and Fede Schelen. And I've done a lot of work with Fede Schelen. He's an obstetrics gynecology professor, and told Dr. Ivan, he's the Dr. Ivan of the Netherlands. So he's also, and he has really, he had been the president of the society, and he really initiated and has led the introduction of competency-based medical education in the Netherlands in obstetrics and gynecology. So what we see often in practice is that we are good in writing up outcomes, what's expected, maybe EPAs, that's untrustful professional activities, things that the trainee must be able to do independently. But what goes less well often in practice, what we often forget as teacher, is to give responsibility to the trainees, to our learners. We often we like to stay in control. So we say, these are the outcomes, you must work towards these outcomes, but then in what we see in practice, it's still teachers centers, still the same structure with tests, and there's no possibilities for the trainee, there's no space to personalize the learning trajectory. So what I have asked is one of the my program directors in pediatrics. So I will use now a video. I have videos in obstetric gynecology too, but they are in Dutch, so I can't use them. This is the only one which is in English, so I will use that. So what we're going to practice is CBME, and the CBME of providing what I think is the essence of CBME is that we assess and give feedback to a trainee. So the trainee is in my hospital here in Maastricht, and what you will see is a patient. You see a big tall man in the back. He's the program director, so the clinical teacher. And you will see a young woman, and that's Dr. Marijke van Aken. She's a trainee. So she is a second-year trainee, and she will see a young child with her mother. Yes, and my question to you is, okay, we are with 100 teachers, so we can give a lot of feedback. So assess this consultation. What do you think about Dr. Marijke as a medical expert, a communicator, and a professional? And you have to assess her and give her feedback. So think, what kind of feedback will you give Dr. Marijke? Oh, wait, sorry.
I would like to introduce ourselves. I'm a pediatric resident, and that's Dr. Breukel. He's the consultant and also my supervisor. Okay. Please, can you tell me why you came here with your son?
Well, my son has been throwing up since a couple of days. A lot. And I'm afraid he's dehydrating.
And how often does he throw up?
Well, every time he's drinking. After that, he's throwing up. So.
Okay. And does he still pee?
Yeah, he pees. Yeah. Yeah, but it's a lot less than it was before.
Okay.
Because Then you read on the internet that babies can dehydrate very fast. So I'm really, really worried.
Does he have fever?
No, 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 no. That's not the problem. But yeah, I'm so afraid that he's dehydrated.
And was he healthy before? Was he already, has he already been admitted to the hospital?
No, the first weeks everything went okay. Since a couple of days now, since 5 days I think.
I'm going to take a look. Take a look at him.
Is it normal? Like, do you feel it? Is it normal? What do you hear, doctor? Is it lungs okay? Is everything okay?
Sorry, but I cannot hear it very well when you're talking, so it's better to be quiet now.
Okay, so you're the teacher of Dr. Marike, and think, what would be your feedback on her as a medical expert, communicator, and professional? Is there anybody who would like to share their feedback?
I'll take that. I think she's a bit too rush and focusing on the lungs more than the patient.
Yes, yes, correctly. So this is typically a situation. So I asked Dr. Hein, what's typically a situation that every pediatric trainee has to be able to do? And he immediately said, you have to be able to cope with parents that are worried, parents that are stressed, parents that interrupt your consultation, why you can't do your amnesia or your physical examination. So what you see is that Dr. Marijke is able to do some of the medical anamnesis, physical examination, but she hasn't learned yet how to deal with parents that are stressed. And for a pediatric doctor, this is of course extremely important. Maybe you need such a skill also for obstetrics, for worried fathers, future fathers. I don't know how they behave in Indonesia, but I know I have 4 children that I always was quite stressed during deliveries. So it's something that you have to learn to work with. And then it's really important. My question is, what do you think that Dr. Marijke will learn from this consultation if you don't provide her with feedback? Think about it. What will she learn? My idea is that she won't learn a lot because she's so still stressed herself because there's a small baby who is possibly dehydrated or other. So she's so focused on the medical aspects of this case that she has no attention at all for the mother and the worriness of the mother. Maybe you know this famous video where you see people play basketball and then somebody in a gorilla suit walks along and nobody sees the guy in the gorilla suit because everybody is focused on the basketball. And it's the same if you are so focused and it's new and you're stressed with getting being capable to deal with the medical aspect, you forget these other aspects. So what's really is important that that she gets feedback. I think this is my feedback. I filled this out. That she didn't address the word mother. And next time, address emotions, parents before starting physical examination. This is also really important so that the feedback is future oriented. So how can you improve the next time? How can you do it differently? So then you work towards development. This is what I call this vertical integration. That's the next case that she will work on this. So I asked Dr. Hein to do, this is what we call a clinical examination, evaluation exercise to give feedback to Dr. Marijke as she does normal. Oh, wait. Yes.
You know, we would focus on the medical aspects of a consultation, but also on communication and professionalism.
Yes.
Okay?
Yeah.
Looking back to your medical history, what do you think your strong points were?
Well, I think I had a friendly way of talking to the mother. And I thought of other causes of the illness of the baby. So I've tried to ask a lot of things to rule things out or to confirm things.
You were capable to exclude the most important, well, diagnostic considerations with relevant key questions. I think that was really important.
Thanks.
Are there some points you would do otherwise next time?
Yeah, I was thinking I forgot to ask for the birth weight and the recent weight. And also I forgot to measure the weight in the physical examination. So that was not good.
Yeah, that was something I noticed as well.
Yeah.
But it's not the most important feedback I would like to give you.
Oh.
Did you notice the mother was very anxious about her child?
Yeah. Well, now you're saying it. Yeah, she was. But I was very focused. I was focused on the vomiting of the baby, and I was thinking what could be the cause of that, and that was why I was ruling out every cause that came up into my mind. So
yeah, I saw you thinking in medical lists.
Yeah,
and
exactly.
You almost forgot the mental state of the model. How do you think you will include that in coming medical histories and physical exams?
Yeah, well, maybe I can explain what I'm doing or why I'm asking things, and well, I can say, well, I see you're concerned or anxious or something, and maybe she feels more happy in that way. Yeah.
Well, we agreed that we would come back to that during your outpatient consultation.
Yeah.
And well, for example, tomorrow, the day after tomorrow, with 2 patients, and then I will give you feedback focused on those points.
Yeah, that's great.
Yeah?
Yeah.
Already filled in your electronic portfolio the lists of communication and professionalism and medical things. And then, well, if you agree, we try to save this. I put my password in.
Yeah.
And then we can save it and we come back to it then tomorrow.
Yeah.
Okay?
Thank you.
Okay, and I think that Dr. Marijke now learns much more from this case than she had learned without the feedback from Dr. Hein. Do you agree with that? Yes, yeah. And what you see here is CBME in practice. So, Dr. Hermant, so there's a conversation between the clinical teacher and the trainee. There's some written feedback for the assessment of the trainee. So now you can both support the development of the trainee towards the outcomes, and you have assessment information to assess the progress of the trainee. So the idea is that you use assessment both for development to support learning and for the assessment of the progress of the trainee. And as you have been able to see on the video, the information goes into a portfolio. So this is a portfolio that we developed in the Netherlands that's also used for obstetric and gynecology. And you see a dashboard, you see a place to insert information. You can follow the progress and this kind of profile, what's typical for the student. So in the progress, you can see that there are all kinds of different assessments, and that per trainee, per period of the traineeship, you can look up things and what kind of assessment has done. But what also is there's both quantitative, so there are scores, but there are also qualitative performance information in the portfolio. So as a program director, you can see where is my trainee, what has he done, where are gaps, where does he have less either experience, or what kind of competencies does she has to work on. And this is really important that you have this. And so you can have an overview per competency, both quantitative and qualitative data points you have. Yeah. And of course, this can be time consuming. And what's really important is that you do this in an efficient way, that you don't want to assess everything. Like, for example, the surgeons in the Netherlands, when they started with modernizing their program and implementing CBME, they did an assessment for every surgery. So sometimes maybe when there are small surgeries, it's 6 a day. That's too much, you know, who's going to look at that information? So better do less, but meaningful, good, than do a lot, but that nobody can, and that it has no meaning for learning and assessment. What can be of, yeah, this is in Dutch, my excuses for that, but we use AI so that you can select, give me all positive feedback about, give me the strengths and the improvements about this competence, so that you don't have to scroll and click to the whole portfolio, but the system gives you points for attention to make selection. So AI can make our life much easier in this progress. Now, to summarize, we have implemented competency-based medical education to educate more broader obstetric gynecologists. So there's more attention to all competencies that are relevant for an obstetric gynecologist. Your profession is extremely complex, so you need a lot of different competencies. And to learn complex competencies, that takes time. You have to work to really become good at something, you have to work at that for a long period. It's not like the example of communication with the surgeons. It's not possible to learn to communicate in 1 week. You have to give attention to that the whole 5 years. We use workplace-based assessments in which where the essence is that there are observations and that teachers provide feedback to the learner and that this feedback is discussed. And the learner must have some responsibility for their own learning, for their own development. So that's in summary the what, why, and how of competency-based educations, and why why time is not a proxy for time. I thank you for your attention, and I'm looking forward to the other presenters. And if you want more information, there's a lot of information on my website. Okay. Dr. Ivan.
Thank you. Sorry, I pressed the wrong button.
Oh, sorry.
I was just going to upload.
Thank you.
Dr. Nisa, is there any questions from the audience? Written? No? No questions? Can I ask you questions, Prof. Eric?
Yes, of course.
Yeah, it is interesting why you mentioned about the patient safety. And then for the what is I still don't get the vertical integration. Can you tell me more specifically about that?
Yeah, normally what we often do, you learn, you go a period, you have courses or traineeships, and there you learn everything about one competence or one topic. You do a test and then it stops. That's how we normally organize, and you do that for a certain period, and we have done that period, then it stops. With with vertical integration, I mean that over the years, so that's what I mean with vertical, so that in these 5 years, there are certain periods where there is the focus on, let's take, for example, normal deliveries, or how you collaborate in healthcare teams. So that's, for example, okay, I'll take as an example the structure of obstetric gynecology program in the Netherlands because I'm familiar with that. So all trainees begin with a general traineeship in a city hospital where they do normal deliveries. But one of the competencies is that you lead the team during the delivery, that you are responsible, that you give clear instructions. So the first half year, that's the main topic. But that topic comes back in the second year again, because then maybe you do more complex deliveries, but you still have to, even more important is how you lead the healthcare team, how you instruct we have a system with midwives in the Netherlands, for example, how you instruct the midwives, how you instruct the pediatric, if there are complications, the pediatric team, or so that was the competency of leading a healthcare teams comes back over the years in different traineeships, and that's what I call with vertical integration.
Okay, thank you.
Yeah.
One more,
So
please.
can I add one more thing?
Yes, please.
What you make for a program, you make a matrix with
Matrix.
all the competencies as rows and all the traineeships as columns, and you look what traineeships can we get information, can we put focus on which competencies. That's what I mean with, that's how it looks in practice. Yeah. Sorry.
A matrix of competence and the name of the residents. Okay.
Yes.
Yeah.
Mr. Prof. Chitra needs to go for her
Yeah.
surgery. If it's okay, we'll just move to Dr. Chitra.
Yeah.
Yes.
And we'll come back to Prof. Eric again.
Yes. Thank you, for Eric. Let's proceed with Prof. Chitra. Please, you will deliver your presentation or only question and answer session?
Yes, hello everyone. My name is Citra Matar and I'm from the National University Health System, National University Hospital of Singapore. And I'm also faculty of National University of Singapore. I hope you can hear me. I did, in fact, say that I didn't have any slides, but I managed to find an old presentation, not that old, don't worry, of our residency program. So I've been invited by the organizers to speak about the residency program. So I would like to share these visuals with you so that you have a better idea of how we have organized the residency. So I hope you can see my screen. I took over as program director of the NUHS residency program in ONG just about 3 years ago. And prior to that, I'd always been involved in education as a clinical teacher, and then later on as faculty in the department. Because I'm a clinician scientist, I my main role was to guide residents in developing their research interests. And also, I'm in the specialty of maternal fetal medicine. So I did a lot of procedural training as well. So when we had the opportunity of revamping the residency program, we had already been with ACGME for about 10 years or so. And when we joined ACGME, ACGME International, we transitioned from a 3-year basic training and 3-year of advanced training to a seamless 6-year program. As you may already know, ACGME covers 4 years of residency. So that coincides with our first 4 years of what we call junior residency. So from year 1 to year 4, junior residents will train and then take their exams and then exit the junior residency program. And the 4 years are covered under the ACGME International. So we were beholden to ACGME for various competency assessments and so on. And in the last 2 years of the 6-year program, they're senior residents, and they come under the Ministry of Health, which has its Joint Commission in Specialist Training, which oversees all the specialty trainings in Singapore, including family practice and the surgical and the non-surgical disciplines. So now we are going back to MOH. We are no longer going to be officially under ACGME, but we are going to be holding a lot of the ACGME principles in terms of assessing the residents in their various skills. But we also have a couple of other key performance indices, not just with the residents going through the residency program and exiting the program, but we also have obligations to develop the residents in alignment with NUHS and NUS. There are 3 pillars of the 3 pillars of the clinical community are education, research, and service. Education for both undergraduate and postgraduate students, service, clinical service, as well as service to public health and public education, and then, of course, research. So we need to incorporate that into our residency training program because it is a pipeline at the end of which we hope to produce master clinicians, clinical educators, as well as clinician scientists. So we asked a couple of questions. We asked ourselves what we really want to achieve during the residency. And as it is a 6-year program, we're starting out at the first year with very junior doctors, young doctors who we presume do not know very much about medicine or surgery. And at the end of the 6-year program, we want a very good, well-grounded, excellent clinician who is well-versed in both obstetrics and gynecology. Not a specialist, but one who is ready to become a specialist. We want to focus on medical knowledge, clinical skills, and of course, the right professional attitudes to get through in their career. This is our vision for the program. And so our mission is also aligned with that. We want to ensure that all the residents we have fair and equitable access to all the resources. We also want to go the extra step and supply additional resources for our residents. So not only do they know how to perform their clinical skills, and not only are they competent clinicians, but they must also know how to function in a hospital that is an academic center. They need core research skills, they need to know how to do quality improvement programs, and they need to know how to do audits and lead audits. We have the opportunities to also develop them as leaders for the future in service, in quality, in education and research. So we want to really instill the love for these additional skills or services for them during the residency itself, so they can be ready for the future. So I'm going to give you an example of how we go about doing it. This is the residency handbook, and it's just a snapshot in which we state our vision, our mission, and also the educational goals. These educational goals are based very much on ACGME. So if you go to ACGME International, we have there are recommendations for developing medical knowledge and clinical skills. which we have adapted to our educational goals for the program. This residency training matrix, again, is adapted from ACGMEI and incorporates the clinical knowledge examination, which is CREOG, CREOG. So the residents have to take from year 1 to year 5. Ours is a 6-year program because we have decided that it is a good benchmark of their clinical knowledge, and their score in the CREOG exam, which runs annually, also is a good indicator of how likely they are to pass their main exams. Now, what are those main exams? Our residents take the MRCOG Part 1 before they come into the residency program. In fact, it is a requirement for new residents to have their Part 1 already before they apply for residency in ONG. They have to take their Part 2, which is a written exam, and that they typically will do in year 3 or year 4. And then they take their Part 3 exam, which is their oral exam, after at least 48 months of training. So they typically will take this in year 4. And they need to pass their RCOG Part 3 and become members of the Royal College before they then are promoted to the senior residency, which is year 5, year 6. So they're stuck in year 4 if they don't pass their Part 3 exams. And after they pass their Part 3 exams and they have all the relevant documents that indicate that they've done their compulsory coursework and so on, then they get promoted to senior residency, which is year 5 and year 6. So those are the main exams that they take during their residency. And at the end of year 6, we have a local exit examination, and that is conducted by the College of Obstetrics and Gynecology in conjunction with the Joint Commission of Specialist Training, who then award the residencies their certificate of completion of residency. Then following the completion of year 6, they are now senior service registrars or specialist registrars, and then their promotion will be handled by the hospital. So they transition from residents under the Ministry of Health to junior consultants, senior registrars stroke junior consultants at the hospital level. So this is a snapshot of how the training is broken down from year 1 to year 6. So we focus on our core skills, which are clinical, procedural, quality improvement, audits, research, and leadership, as well as developing them as clinical teachers in the first 4 years, especially, and then we hone their interest in year 5 and year 6. And the curriculum is developed by the core faculty. So the core faculty, which is under myself as program director and the assistant program director, we have the core faculty takes care of the curriculum in gynecology, obstetrics, and primary care, with primary care being one of the core domains in ACGMEI. Then we have somebody who takes care of welfare and research, as well as a team that takes care of the exam preparations. And under the clinical skills, we concentrate on training in surgery, reproductive medicine, and the subspecialties. We also have family medicine trainees who come under us and spend about 3 months with us for development of their knowledge in women's health. And then finally, we have the core faculty who concentrate on developing procedural skills, such as open surgical skills, minimally invasive and robotic skills, as well as obstetric procedural skills. So this is the breakdown of the core faculties, the core faculty portfolios, and the core faculty are those within the department who are tasked with the responsibility of preparing our residents. So Professor Mahesh Chulani is our head of department. These are my core faculty. So this is myself and Pearl, who are the overall directors. We have a couple of our core faculty who are in charge of exam preparation. These core faculty are in charge of research development, and our core faculty over here are in charge of our surgical training. So these are MFM, UG, reproductive onco specialists who will train the residents in the specialty fields, as well as take responsibility for general training and professionalism. Our program is broken down, as I mentioned, into 4 years. So into 6 years, sorry. So junior residency is 4 years and senior residency is 6 years. This is how we break it down between obstetrics and gynecology. So in the first 4 years, they're laying their foundation of clinical knowledge. So in the first 2 years, they do general work, and in the second 2 years, they do specialty work. And we cover inpatient and outpatient obstetrics, as well as inpatient, outpatient general gynecology dealing with benign lesions, and then specialty gynecology dealing with urogynecology, reproductive medicine, and oncology. It is also mandatory under ACGME that they have electives. So we have arranged for our residents to have 2 months of electives in their second year, and 2 months, and 1 additional month of electives in their 4th year. So they can do clinical electives, and a lot of our residents go off and spend some time in whatever they're interested in. So they may go to surgical or medical ICU. They may go to the cardiology unit, the cardiology department, and learn about women's cardiology. They may go and spend some time with the anesthetist to hone in their acute medical care skills, or spend some time in the emergency department. So this is to enhance their learning. And some of them with a research interest will do an elective in research. And then finally, in the last 2 years, they have to do a compulsory 6 months in these 4 specialties. So they do 6 months of obstetrics, in which they cover deliveries, labor and delivery at the delivery ward, as well as specialist obstetric care, high-risk clinic, diabetes, and genetics. They also have to do 6 months of benign gynecology. So they cover urogynecology and MIS and robotic surgery. They do 6 months of reproductive endocrinology and 6 months of oncology. They need to be signed off for these 6 months of posting. And that typically comes in the form of their logbooks of cases that they collect, a competency interview, and then the competency review, which is done by the faculty and the head of division before they're signed off for the 6 months. And if they don't meet the requirements, then they don't qualify to take the exit exams. Yeah, so this is what responsibilities our residents have, and I think it's fairly similar in a lot of our residency programs. So they work they work in the clinical spaces, but in addition to that, they have to do a lot of other teaching and learning as well through journal club, presentation of mortality and morbidity rounds, risk management, and then they do the specialty rounds like perinatal, oncology, tumor boards, and so on. And they do various other workshops to hone their skills. We hold surgical workshops for them where they where they do cadaveric dissection to learn surgical anatomy and so on. We host many different master classes for the entire faculty, but the residents, of course, benefit from this, and they can use their residency training fund to buy membership as an RCOG associate. So they have access to all the RCOG materials, as well as the Incision Academy, which is a surgical training academy. So it's multidisciplinary, and it's supported by both the department as well as NUHS residency. And these are the examples of the kind of courses that that are compulsory for our residents. So the Anatomy of Complications course is held every year by the gynae oncologists, and our residents always have a seat on the Anatomy of Complications. We also hold a cadaveric pelvic surgery workshop. We collaborate with the Department of Anatomy as well as general surgery and colorectal surgery to get access to these cadaveric pelvises, donated cadavers, so that they can learn surgical anatomy. This is an example of the hands-on workshops that we have. We also run workshops in MIS, in OASIS repair, and robotic surgery using a combination of simulation and tissue models. We have a prompt course, which is the obstetric emergency course, and we also do a difficult deliveries course where they can learn how to do forceps vacuums and other obstetrics procedures on mannequins. We have also carved out core time in the curriculum to send the residents to the laboratory so that they can embark on research training. we have actually just initiated this 2 years ago. So during the 2 months in the second year, they learn epidemiology, biostatistics, clinical trials design, and they get some exposure to wet bench laboratory work as well, because there are a number of principal investigators, scientists within the Department of ONG who do basic and translational research, and we believe that our residents need to be exposed to this. And all of this is to really build a pipeline so that our residents will not just come through with their exam certificates at the end of the day, but they will also be on a pathway where they can then proceed to develop their career as soon as they come out of residency. So the majority of residents will want to be clinicians or master clinicians, and so those with the skills to become master clinicians are then given the opportunity to go on conferences, to do studies in clinical work, to do clinical research, and then they're prepared for specialty training after they finish their residency, so that they can become a master clinician or a super clinician at the end of their residency. And those who are interested in becoming researchers or clinician scientists are also likewise given the opportunity. So during residency, they are able to carve out some time for themselves to do some clinical or translational research. They also are mentored by clinician scientists so that they can do so they can deep dive into research. And the NUHS and NUS systems have the Clinician Scientist Academy and other networks and ecosystems so that they can hone their skills. Then eventually we advise them to and encourage them to do their PhD so that they can get all the credentials of a bona fide clinician scientist. And similarly, although I didn't add it here, there is a pipeline for a clinician educator. So those who are interested in teaching, we make protected time for them during their residency to teach undergraduates, family medicine residents, and other junior residents. And then we eventually encourage them to pursue a PhD in education after their residency is completed. So we want to make sure that our residents are also in a position to develop themselves as thought leaders and to be ready for the future of medicine. And we all know that the future of medicine now is very heavily leaning towards artificial intelligence, machine learning algorithms, robotics, etc. And so we hold a lot of conferences where we invite speakers who are in this field to speak with the faculty, and that includes the residents. We also try and involve them in not just research, but in daily work. For example, if they are doing the roster, we talk about how we can get agentic AI to help us to do the roster more efficiently. And if they are helping to set up events like public forums or master classes for other clinicians, we also try and incorporate the newer available technology into our work so that everybody is used to it, and advances in medicine in general and medical technology are seen as something to be expected and something to be leveraged upon rather than something else, rather than something completely foreign. ACGME also requires us to do a survey. So this is just an example of an ACGME survey. And of course, every year we do get things that we don't expect. And sometimes sometimes we have to wake up because we think we're doing well, but actually the residents don't think that they're getting enough nurturing or enough time to rest and so on. So we're constantly tasked to review our working hours. Working hours are very important under ACGME. That's the most important thing, I feel. And a lot of us acknowledge that residents' working hours cannot go beyond 80 hours. So we have worked hard to enable our residents to take post-call after they do their on-calls. And this is just an example here of the residents' hours. how many days off they have in average, how many of them have the mandatory 8-hour rest period, and they can't do more than a certain number of calls at a certain frequency. So we know that our residents, we keep tab of our residents' hours, and we know that they don't reach 80 hours. In fact, most of them will reach just about 55 to 65 hours in a certain week, even if they're doing 6 calls a month, which is what they will typically do, because we have worked it into the program such that now they're getting they go off post call when at 8:30 the next morning, so they don't have to work a regular day or even half a day when they finish their call. So this is one example of these are some examples of the changes that we have made, and we are with the annual reviews, we're also constantly forced to review our educational content, our resources. We also have to make sure that our residents get enough caseload. One of the things about our hospital is that we are middle size. We do about 4,500 to 5,000 deliveries. So we're not a very large hospital, but we have enough clinical materials for our residents. And we review the residents' caseloads every 6 months so that we know that they are on track to exit the junior residency and eventually to exit senior residency, because they have a minimal caseload for junior and senior residency. These are the examples of the cases that they have to log for junior and senior residency. And then they also have to do extracurricular activities. So we provide them with the opportunities to do various things, including going on residency leadership courses. Yeah. This is just an example of the kind of pass mark that we get in our part 1 and part 2 and part 3, as well as our exit exams. And this is because we make a concerted effort to sit down and make sure that they are trained for the exit exams. And we have won a couple of gold medals as well in their exams. So this is an example of how we prepare them. We do a circuit of maybe 3 stations if it's a short circuit, or 12 stations if it is the full circuit, just to put them through their paces and make sure that they know how to answer the questions, how to present themselves properly, how to demonstrate a forceps delivery on a mannequin, and so on. So we do exam prep for our ONG residents, and our residents and faculty also do exam prep for family medicine residents as well. Yes, and during residency and after residency, we also give them an opportunity to pursue masters and specialist diplomas in various things when they have declared what their interests are. Our residents also attend conferences, and they present papers at conferences. They present oral and poster papers. They're acknowledged for their teaching of undergraduate medical students. And then when we have visiting faculty, we try and take out some time for the residents to meet with the faculty, because sometimes they are, for them to be inspired by these specialist faculty. This is an example of the local and international conferences where we support residents, going and presenting their work. And we also look at their well-being. So again, under ACGME, we look at the residents' well-being. This is another compulsory annual review that we do. And of course, we have to do a lot of post-mortem as well. So if we get feedback where residents are not happy with the residency program, or they feel that they're being overworked, they have less time to pursue their interest or to recover, etc., then we look at that critically so that we can make changes where the changes are due, and we can make an improvements of the things that we are able to control. Yeah. So we can't, of course, change everything. We can't improve everything, but we can actually do certain things that make it more, that make the residency more comfortable for them. And we take care of the teaching as their mental well-being as well, particularly after they've had they've been involved in incidences which have led to bad outcomes or that are near misses. We sit them down in a closed door session, and we teach and reflect on the bad outcomes that have come about. We try and do this as anonymously as possible, because we are not fault finding, or we're not trying to lay fault at anybody's feet, but we're trying to elevate everybody's knowledge and professionalism by reflecting on the cases where things went wrong and where mistakes were made, so that people will what the mistakes are, especially those who are coming up and becoming, clinical leaders and clinical seniors. We also have, very close overview of what our residents do. So our residents are never left on their own. They have to consult their consultants and the senior consultants who are on duty with them, because we don't want them to take responsibility of patients unnecessarily and take on unnecessary risks. So we closely monitor them while allowing them to try and work as independently as possible. Right. And so just the last slide, this is an example of what they talk to us and the concerns that they raise. So if there are any concerns that are raised, we typically try to change to try and address the concerns and change the things that we can handle at the residency level. But we are well aware that there are certain things that are at the department level or at the hospital level, especially infrastructural and regulatory issues that we can't change. And so we accept that there are some things that will always be bugbears for the residents in the program. But at the end of the day, we try and be as transparent as possible. So by transparent, we mean that we tell the residents from the very beginning of their postings, this is how you're going to be assessed, and this is how you're going to be developed. So we want to spend time developing clinical, organizational research, education, administration, and leadership skills. And this is how you will be assessed every 6 months until the end of your residency. And at the same time, the residents also score the faculty and the residency program using the same set of criteria or Coriel. And this is just an example of the residents' evaluation of the program, the core faculty, as well as the postgraduate director and the assistant postgraduate director. Okay, so the residents will have a say in how the program runs. They'll also have they'll also know upfront what is expected of them from their residency. They know that they have a lot of opportunities to train up in skills. A lot of them are quite keen to be surgeons and to be proceduralists. So they are taken through their paces from the first year of residency. This is an example of the prompt course where we simulate maternal collapse and breech deliveries and PPH and so on. And recently we have also introduced operative obstetrics, which has proved quite popular with residents. We also bring in the SingHealth residents, so we take care of the Western cluster. The Eastern cluster is under a similar but a separate program. So we do combined training like this difficult delivery course, so we can ensure that all the young residents in Singapore have a similar opportunity. We try and set aside some money from the department to support the residents. And under MOH, residents also can score the quality of the program. So so annually we are expected to review the program, and we have opportunities to make changes as well with regards to the feedback that we get. Okay, so this is my last slide. I hope that has given you a brief overview of how we conduct the residency program in Singapore. There are, of course, many areas for improvement, but I think overall we have a clear understanding and clear picture of what is required for residency in order to develop the kind of clinician that we will need going forward for the rest of the 21st century and the 22nd century. Thank you very much.
Thank you very much, Prof. Chitra. Is there any still enough time for questions? One questions maybe, Prof. Chitra.
Sure.
Yes. How about selection for resident candidates? Is it from nationally, or how you select the residents?
Thanks. The residency selection process is fairly complex, but we try and select residents who can bring diversity of skills and diversity of interest to the program. And so the selection process starts with the submission of CVs and application forms once a year to the Ministry of Health. And then the Ministry of Health will send these CVs to to all three hospitals. We have three public ONG hospitals in Singapore: NUH, Singapore General Hospital, and KK Women and Children's Hospital. And so we get the CVs, we all get the same CVs, and then we can determine how many of those residents we want to interview. We are also informed every year how many residents we can take, and that depends on the manpower and depends on the projection of specialists needed in the future. So typically we take in about 5 residents a year, and this has come up over the last 3 years from 3 residents. So that may seem like a small number, but as I mentioned earlier, we have about 4,500 to 5,000 deliveries a year. And we also don't want to be too overcrowded because we want our residents to have a fair opportunity to learn surgery and to do cases and manage patients and so on. We don't want too much overcrowding in our clinics. But at the same time, we want enough residents so that they don't have to do too many calls or extra working hours. So 5 a year is the current number, and we typically will have about 20 to 25 applications. So we will go through the first round of applications and shortlisting, where we look at the CV. There are a couple of things that are compulsory, like MRCOG Part 1 and a clear intention to do ONG as a long-term career. A lot of them will have very similar CVs because they would have done quite a bit in medical school in terms of research, voluntary work, volunteering on missions, teaching, and so on. So there's not a lot to distinguish the applicants, but then we look at their CV to see how much experience they have had in postgraduate training. So have they gone off and done postings in colorectal surgery, general surgery, and so on. So if they have had additional experience, we know that when they come to us, they're older, they're more mature, they have more clinical skills, training, and they are more likely to be able to handle the workload and the mental and physical stress of a surgical discipline. Then after we have shortlisted all of them, after reviewing their exams, their CVs, and also reviewing whether or not they've had any negative reports or any citations for unprofessionalism or serious outcomes, then we will typically interview about 10 to 12 residents or candidate residents. When we interview them, we put them through a couple of stations. So there'll be an interview with a senior faculty panel where we talk about their future goals and we talk about whether or not they are aware of current trends or current topics in medicine in general and in women's health in particular. Then there's an interview with a junior faculty panel where they sit with the residents and residents will talk to them about scenarios and assess how they handle the typical stress that they will experience in their first few years, not having a lot of sleep, having multiple people calling them at the same time. We put them through a surgical station so they can demonstrate their skills on a mannequin, and then 1 or 2 other stations where we can talk about certain focused tasks or topics. This gives us a feel of how they present themselves, what kind of experience they have, how they see themselves in the long term, and most importantly, how they fit into an academic center. Because we're quite clear that we're an academic center, so therefore we want our residents to develop as academic physicians in whatever capacity, whether as an educator, as a researcher, as a master or specialist clinician. And we want people with a long-term vision of how they can contribute to academia, to academic medicine. So this is the way we construct our selection, and typically there'll be about 3 or 4 candidates per residency post.
Oh, thank you. So if I'm not mistaken, that you have five resident a year and 4,500 deliveries a year, and the duration of the training is 6 years, and you have 50 to 60 hours working hours for the resident. Is that correct?
So it turns out to be that, yeah, it turns out to be on average about 60 to 65 hours per week. The maximum is 80 hours. We shouldn't go beyond 80 hours. And it will depend, of course, how the residents log their hours. But because we give them a post call, that means I work for 24 hours. And then after that, I clear up whatever is left of my work. I do my training and then I go off. We find that they don't breach the 80 hours a week. Oh, I forgot to mention that under ACGME, it is also compulsory to protect 4 hours a week for their training. So that can be done in different ways. For example, at KK Hospital, they will dedicate one Friday afternoon from 2 to 6 p.m. just for residency training. So they will go through, they'll do journal club or they'll go through simulation during that time. So it's a 4-hour block each week. And we do ours as a 1 hour protected training a day. So from 7:30 to 8:30, we will the residents have to, it's compulsory for the residents to attend this meeting. The faculty attends it as well. So we'll go through journal clubs, topical reviews, we'll go through M&Ms, maternal and morbidity and mortality meetings. We'll go through, other things, research reviews, research presentations and so on. So that is our compulsory 4 hours of training per week.
Last questions. You mentioned Ministry of Health many times, and you never mentioned Ministry of Education. Is that right?
Yes, that's correct. Yeah, yes, very astute. Yes, I understand in some places that the training may be under the Ministry of Education, but in Singapore, it's all under Ministry of Health. So Ministry of Education doesn't play a role in the postgraduate training of our clinicians. And that's because clinical training falls under MOH. And if our residents are training to be clinician educators, that falls under the institution or the university. But eventually, some of our residents will join the National University of Singapore as faculty, or if they are in other hospitals, they may join the other universities as faculty. So then the universities are under MOE. So, for example, I'm faculty of NUS, and that's under MOE. So I will be under MOE. But our residents are all under MOH.
Oh, so you don't need exit exam or licensing exam. The same for you.
Yes, that's correct. Yeah. So the exit exam and the certification of specialist training and the ability to work as a specialist is granted by MOH.
Yeah. Thank you very much. Dr. Kanadi or maybe Dr. Ivan, is there any comment?
Silakan Dr. Kanadi.
Well, thank you very much, Professor Chitra, for your enlightenment, because it's very stunning to listen to your explanation for all the complete metrics of residency training in Singapore. I guess, yes, I think we have to have a lot of improvement, especially we still do not pay any attention regarding to the, especially the resident welfare, because I guess it's a very common issue nowadays. And also, I really appreciate that you guys really focus on the how much residents can have enough case for their competency, because I think like you already mentioned previously that numbers of candidates that will be taken a year basically have to see the availability of the numbers of case and the kind of case. I think it's a very true condition, and bit nowadays I'm a bit concerned because in our side basically this kind of evaluation is not really done very well. So I see many residents basically still lag behind the clinical exposure. So therefore, I think there's no such good evaluation. So therefore, and there's no consequences at all. You guys has already have a very good quality assurance, like you have the assessor from global like ACGME, but nowadays we still have a local assessor. So I think many things to learn, many things to be improved in our sites. So thank you so much for your information regarding to the how Singapore train their residents. Thank you so much.
Okay,
Most welcome.
thank you.
Can I
think
just ask one
one
point
question.
about your supervisors? So
Sure.
the supervising specialist, peer-based, right? So is there a condition when you need to have to be a subspecialist to train specialist, or you have all specialists to train specialists? How does it work there?
Thanks. Yeah, thanks. No, the supervisors for residency are not necessarily responsible for that training. So I can be a non-operating gynecologist. So I don't do any gynae surgery, and I do mainly obstetrics, for example. But I can still be a supervisor for the residents. The supervisors are tasked with ensuring that the residents have somebody to speak with or to approach if they are finding any difficulties in either the training or the opportunities they get, or even if they have, case incidents in which they're involved, where they need advice as to how to handle it and so on. So our supervisors are there to make sure that our residents have somebody outside of the faculty to seek advice from. And we try and ensure that the supervisors have time for the residents. So the super busy clinicians who don't have time for the residents don't make the best supervisors. We try and ensure that we pair them up. By personality, although that doesn't always work out. And there's no problem for a resident to have more than one supervisor in case, they get good surgical training and advice from one supervisor, but that person is not really taking care of their welfare. We try and find somebody else for them. And so we want to ensure that residents are not neglected, and they don't feel that they don't have, somebody with whom they can speak confidentially. So our supervisors do change every year because we want a mix of both young and older faculty as well. Sometimes our older faculty are wiser and they make better supervisors, but our younger faculty are more closely aligned with the needs, the requirements, and they maybe perhaps sympathize a little bit more with our young residents, and they know what the residents are going through. So we try and keep the mix fresh, and we try and change our supervisors every couple of years so that residents have exposure to different consultants.
Thank you.
Okay, thank you. Thank you, Prof. Chitra. Maybe you have some other activation.
Yes,
Thank you
actually,
very
I had
much
to go
for your
to
presentation.
go and attend to a patient now. But I just want to say that on behalf of the College of ONG, we're very happy to work with the Indonesian College if there's any area in which we can collaborate with regards to residency.
Yes, thank
Thank
you.
you.
Alhamdulillah. Thank you.
Let's send regards
Thank you.
to
Assalamualaikum.
Professor
Thank you
Jason.
very much for
Waalaikumsalam.
hosting me. Assalamualaikum. Take good care. Bye-bye.
Salam. Okay. Well, we proceed with the third speakers, Professor Titi Savitri. Please deliver your presentation in 20 minutes. Yes.
Okay, thank you very much. I would like to appreciate Dr. Ivan and all colleagues from College of OBGYN for organizing this very important meeting. I'm a medical educator, and I would like to present more from the perspective of medical education, how to design competent-based curriculum. And maybe I will speak in two languages to make it easier. So for many years, a lot of centers applied time-based residency program, which is a model in which doctors complete a fixed period of training and prescribed clinical experience, with progression determined mainly by elapsed training time. Characteristic of time-based residency training is fixed training durations, and it has structured rotations with a certain period of time, also progressive responsibility like chief resident, junior resident, senior resident, etc. And also time determined progression. Nah, jadi kemajuan residen dilihat dari penyelesaian rotasi atau durasi yang harus dilengkapi. Kemudian it is predictable and from administrative point of view it is simple, ya. It is not difficult to organize time-based residency training. And as opposed to time-based residency training, we have competency-based residency training. It is a residency model which residents progress when they demonstrate competence. Often it is expressed in the milestones or entrustable professional activities rather than simply completing years of training. And so when we talk about competence in fact is a multiple domains, ya. Jadi kompetensi itu bukan hanya pengetahuan saja, skill saja, atau sikap saja, tapi kumpulan ketiganya. Satu pernyataan kemampuan yang meliputi beberapa domain, ya. Kemudian it is multidimensional and dynamic. Jadi kompetensi itu dinamis, bisa berubah, it changes with time, experience, and setting. Jadi kalau settingnya berubah, kompetensi juga bisa berubah. Dan kompetensi biasanya gabungan dari ketiganya, dan it can be observed, ya, and it can be measured to ensure their acquisitions. And when we talk about competency-based medical education, in fact, competency-based medical education is an outcome-based approach to design, implementation, assessment, and evaluate medical education programs. Jadi KBK atau kurikulum berbasis kompetensi itu sebetulnya adalah juga suatu outcome-based education, pendekatan berbasis outcome, ya, OBE yang sering disebut di negara kita. Merupakan suatu pendekatan untuk merancang, mengimplementasikan, menilai, dan mengevaluasi program pendidikan. Dan itu biasanya dimulai dengan penetapan outcome atau kompetensi, lalu backward, ya, mundur ke belakang, working backward, untuk mengidentifikasi milestone, lalu proses dan assessment-nya. So characteristic of competency-based residency training is it is based on competency achievement and also EPA achievement, dan yang penting adalah flexible duration, waktunya fleksibel, individualized. Jadi di dalam OBE atau competency-based education, dua hal ini sangat implikasinya cukup dalam, ya. Jadi masa studi itu fleksibel duration, dan kurikulum itu individualized. Nah, kurikulum individualized ini kalau saya analogikan, ya, biasanya kurikulum itu sama untuk semuanya. Nah, itu seperti kita nasi kotak gitu kan. Setiap orang mendapat porsi yang sama. Tapi kalau individualized kurikulum itu seperti buffet atau prasmanan. Setiap orang mengambil sesuai dengan keperluannya, sesuai dengan kebutuhannya. Nah, ini ilustrasi yang paling gampang. Nah, dengan demikian, karena dua hal ini, flexible duration sama individualized, maka beban administrasinya lumayan. Ya, tadi kalau kita lihat contoh di Maastricht maupun contoh di Singapura, membutuhkan dokumentasi yang cukup intensif, ya. Biasanya menggunakan AI tadi untuk memudahkan, menggunakan LMS, ya, electronic portfolio, dan seterusnya. And the important thing in the competence-based residency training, it de-emphasizes time as primary indicator of completion. Jadi penyelesaian program pendidikan itu dasarnya bukan telah menyelesaikan suatu rotasi dengan waktu tertentu, tapi telah mencapai kompetensi, gitu. Nah, ini ada tulisan di Academic Medicine yang lebih mendetailkan, gitu, kekurangan dari time base, ya, time base model yang sudah diterapkan bertahun-tahun, serta keuntungan dari advantages dari competence based model, ya. Memang kalau secara konseptual itu lebih banyak manfaat dengan menggunakan competency based. Tapi nanti kita lihat secara praktis ya. Tadi apakah competency based residency training itu membutuhkan resources yang cukup besar gitu. Nah, salah satu ini tadi in the competency based residency training penting sekali untuk menentukan milestone ya. Sebetulnya di kurikulum yang sudah ada itu kan juga sudah ada milestone yaitu tahapan ya, mungkin tahapan junior resident, kemudian senior resident, lalu chief ya, mungkin kadang-kadang R1, R2, R3 ya, lalu chief gitu. Jadi milestone itu adalah petanda ya, petanda yang bisa diamati dari pencapaian seseorang dalam kontinum pendidikan gitu. Milestone are used for planning and teaching. So the implementation of milestone is an important point in the competency-based residency training. Nanti kita lihat seperti apa milestone-nya. Nah, milestone yang banyak digunakan adalah dari Dreyfus ya. Jadi Dreyfus ini membagi tahap perkembangan seseorang ini banyak digunakan di dunia kedokteran, baik undergraduate maupun postgraduate. Walaupun aslinya si Dreyfus ini mengembangkan model ini dengan mengamati pilot gitu. Tapi lalu model ini digunakan di medical education. Mulai dari novice, advanced beginner, kompeten, proficient, kemudian expert, lalu mastery. Ya, jadi awalnya ketika mulai pendidikan, residen R1 adalah tahap novice mungkin ya. Kemudian berikutnya tahap intermediate atau advanced beginner, tahap kompeten dan seterusnya. Nah, ini sering juga disebut level 1, level 2, level 3, level 4 ya, atau milestone. Milestone 1, milestone 2, milestone 3, milestone 4, milestone 5 gitu. Nah, dari setiap milestone itu nanti perlu dikembangkan kurikulum dan asesmennya ya. Jadi untuk milestone 1 tingkat novice seperti apa capaian pembelajaran yang mau dicapai ya, outcome yang mau dicapai, lalu bagaimana asesmennya ya, bagaimana prosesnya gitu. Demikian untuk setiap milestone. Nah, kalau kita lihat tadi karena individualized ya, jadi salah satu ciri outcome based education atau competent based education adalah kurikulumnya itu individualized. Jadi setiap orang, setiap residen mungkin bisa berbeda-beda ininya, apa namanya, pencapaiannya. Ada residen yang mencapai di sini ya, ini tadi. Ada yang mencapai di sini, ada yang mencapai di sini begitu. Tapi ini sebagai patokan saja. Dalam kenyataannya setiap orang itu pencapaian milestone-nya bisa bervariasi. Ini yang disebut dengan tadi flexible duration, flexible duration. Jadi milestone itu seperti kita membangun rumah ya. Sebelum membangun rumah kita punya desainnya dulu. Ya, jadi ketika kita menyusun kurikulum, we have kurikulum design first ya, which we call curriculum map ya, peta kurikulum. Lalu kita membangun fondasinya ya, kita membangun blueprint ya untuk setiap unit atau setiap modul, lalu baru mengembangkan modul tersebut ya hingga akhirnya bisa menjadi rumah yang utuh gitu. Nah, ini tadi. Ini definisi dari Dreyfus model tadi, novice, advanced beginner, kompeten ya. Jadi kompeten itu able to perform the tasks and roles of the discipline, tapi terbatas ya. Jadi kompeten itu bukan berarti sudah mampu ya. Sering kita menyatakan oh dia belum kompeten. Oh kalau udah kompeten dia udah lulus uji kompetensi nasional berarti kompeten gitu. Jadi sebetulnya definisi kompeten itu adalah bisa perform task and role pada waktu ujian gitu. Jadi terbatas. Nah, level berikutnya adalah proficient atau mahir kalau kita ya, mahir. Jadi mahir ini sudah melaksanakan berkali-kali dan memiliki konsistensi and efficiency in performance of their task and role. Jadi sudah melakukan mungkin delivery, sudah melakukan SC berkali-kali itu konsisten, efisien performanya ya. Expert ini biasanya sudah spesialis, subspesialis itu sudah mastery ya, sudah mampu melakukan kasus-kasus yang kompleks, yang lebih sulit gitu. Nah, milestone tadi ingat ya, jadi kompeten ini dari novice, advanced beginner, kompeten, proficient ini disebut milestone dan masing-masing ini dikasih label milestone 1, MS1, milestone 2, milestone 3, milestone 4 dan seterusnya. Nah, saat ini di banyak negara muncul istilah EPA ya. Mungkin pernah dengar juga, EPA itu adalah Entrustable Professional Activity. Ini kalau dibahasakan adalah tugas-tugas klinik ya atau tupoksi. Tupoksi seorang apa residen tupoksi seorang dokter spesialis obsgin ya. Nah, itu adalah EPA. Nah, untuk bisa mengerjakan satu EPA membutuhkan beberapa milestone gitu. Nanti kita akan lihat. Jadi seperti ini ya. Ini juga menggunakan domain kompetensi dari ICJMI ya. ICJMI develops 6 domain kompetensi ya. Ada patient care, medical knowledge, system based practice, practice based learning, interpersonal communication skill, and professionalism. Nah, masing-masing domain ini kemudian di breakdown ya menjadi subkompetensi ya. Subkompetensi 1, 2, 3 dan seterusnya. Nah, masing-masing subkompetensi ini kemudian di breakdown menjadi milestone ya. Milestone. Jadi untuk subkompetensi 1 disebut novice apabila apa gitu, ada definisinya. Disebut advance apabila apa gitu. Jadi untuk masing-masing subkompetensi dibuat ininya milestone-nya ya, baik milestone 1, 2, 3, 4, 5. Nanti kita lihat contohnya ya, sehingga secara keseluruhan tadi satu EPA membutuhkan beberapa EPA nih ya. One EPA comprises of several domain of competencies and several competencies consists of several subcompetencies ya. Subcompetencies consists of several milestone. Jadi ini ujungnya adalah EPA gitu. Nah, kenapa di praktek di klinik tidak menggunakan kompetensi? Karena begini, kalau kita di klinik kan nggak mungkin. Coba kamu terapkan medical knowledge gitu kan nggak mungkin. Yang ada adalah coba pasien ini dilakukan tindakan USG misalnya atau dilakukan tindakan tertentu. Jadi EPA itu sebagai apa ya implementasi dari kompetensi ya. Karena di praktek kompetensi itu kan kemampuan. Yang di praktek yang dilakukan adalah tugas-tugas gitu. Nah, untuk melakukan tugas itu diperlukan beberapa kompetensi gitu. Kan nggak mungkin di praktek, coba kamu lakukan communication skill kan nggak ada. Yang ada adalah coba pasien ini kamu tangani ya. Mulai dari anamnesis. Nah, yang ada adalah pemeriksaan fisik dan seterusnya. Jadi menata laksana pasien itulah EPA. Untuk bisa menata laksana pasien membutuhkan beberapa domain kompetensi gitu ya. Hubungan antara EPA, kompetensi dan milestone. Ya, jadi ini definisi EPA. EPA is entrustable professional activity adalah is a task in the clinical setting that may be delegated to a resident by their supervisor once sufficient competency has been demonstrated. Ya, typically each EPA integrates multiple milestone. EPA are used for overall assessment. Ya, nah ini contoh karakteristik EPA ya. Dia merupakan pekerjaan rutin dari seorang klinisi ya, kemudian merepresentasikan professional work ya, menuju kepada outcome yang measurable, observable ya, dan membutuhkan beberapa kompetensi ya across domain dan perlu di mapping kompetensi and milestone-nya ya. Nah, ini contoh IPA ya. Contoh IPA adalah menyediakan home care ya atau memimpin satu tim interprofesional memfasilitasi transition from pediatric to adult healthcare dan seterusnya ya. Nah, ini contoh IPA. Nah, yang perlu digarisbawahi, IPA itu adalah entrustment refers to the ability to effectively perform a professional activity without supervision. Nah, ini ya. Jadi IPA itu adalah kegiatan atau tugas-tugas profesi yang bisa dilakukan, diperform secara efektif tanpa supervisi. Nah, itu ya. Nah, nanti dalam mencapai kondisi without supervision ini butuh tahapan gitu. Nah, ini contohnya ya. Jadi ada beberapa IPA kan, sebagai seorang profesi tadi dokter spesialis obskin memiliki beberapa IPA. IPA 1, 2, 3, dan seterusnya. Nah, IPA ini kapan boleh di-entrust ya? Artinya si residen mendapat kepercayaan untuk melakukan tindakan profesional tersebut. Kapan itu disebut dengan competent threshold di sini ya. Jadi ini artinya bisa di-entrust. Ada keputusan saya mempercayakan residen ini untuk melaksanakan operasi sesar misalnya. Nah, itu di-define kapan gitu ya. Nah, IPA tadi sebetulnya sebagai dasar untuk melakukan level of supervision ya. Level 1 itu belum boleh melakukan IPA. Jadi mungkin ini year one resident gitu ya. Dia masih level 1, level supervisinya level 1, dia hanya observe ya. Misalnya observe dalam operasi pengangkatan miom gitu ya. Tidak diperbolehkan melakukan IPA. Nah, level 2 boleh melakukan IPA tapi dengan full supervisi ya. Lalu level 3 boleh melakukan IPA tapi supervisinya based on request, based on demand. Ya, kalau sewaktu-waktu membutuhkan misalnya lagi operasi tadi pengangkatan miom, ada perdarahan lalu yang tidak bisa dihentikan, baru manggil supervisornya gitu. Jadi on demand. Kemudian level 4 unsupervised. Jadi disinilah thresholdnya tadi, disinilah batasnya. Jadi ketika masuk level 4, seorang residen sudah diberi kepercayaan untuk melakukan tindakan klinik tersebut gitu. Nah, level 5 si residen tersebut sudah chief ya, bisa memberikan supervisi ke juniornya gitu kira-kira. Nah, ini hubungan antara IPA and kompetensi. Ini tadi isi CBME kompetensinya di sini. Ini adalah IPA-nya ya. Jadi satu IPA memerlukan beberapa kompetensi ya. Jadi untuk bisa melakukan satu IPA dibutuhkan beberapa kompetensi. Misalnya high risk complicated delivery. Ya, ini adalah IPA ya, mampu melakukan delivery dengan high risk complication, komplikasi yang risiko tinggi. Maka dibutuhkan kompetensi ini ya. Nah, nanti juga untuk setiap subkompetensi di milestone berapa dia boleh di-entrust, bisa dipercaya. Nah, ini ya. Jadi ini hubungan antara IPA, domain of kompetensi atau area kompetensi, lalu kompetensi dan milestone ya tadi. Jadi misalnya ini IPA-nya mampu melakukan delivery dengan komplikasi risiko tinggi ya, IPA-nya ini. Nah, untuk bisa melakukan itu butuh area kompetensi apa aja ya, butuh kompetensi apa aja, dan masing-masing kompetensi tadi dibedakan menjadi subkompetensi, lalu masing-masing subkompetensi itu kita buat milestone-nya ya. Jadi untuk IPA ini kok C2 kompetensi nomor 2, milestone 1 M1, milestone 2 di M2 gitu ya. Jadi setiap IPA didefinisikan kapan seorang residen itu bisa melakukan IPA, bisa diberi kepercayaan melakukan IPA, maka diidentifikasi ininya. Nah, kalau si residen sudah memenuhi semua milestone ini, ya berarti dia sudah bisa diberi kepercayaan gitu. Nah, milestone ini penting baik bagi residen dan fellow-nya maupun bagi pengelola PPDS-nya ya maupun bagi lembaga akreditasinya ya. Dalam hal ini misalnya Lampetekes gitu. Nah, ini contoh bagaimana setiap subkompetensi itu dipecah ke dalam milestone level 1 sampai level 5 ya. Jadi ada kompetensi, subkompetensi, lalu level 1, level 2 tadi ya, level 1 novice resident, level 2 advanced beginner resident, level 3 competent resident, level 4 proficient resident, level 5 resident expert atau fellow expert ya. Nah, kalau level 1 dia masih brand new to the specialty, level 2 perform some tasks with limited autonomy, level 3 perform common tasks with autonomy, level 4 target for graduation, level 5 exceed their peers. Nah, ini contoh example of how we develop milestone for competency number 5, patient care, and sub-competencies, urgent and emergent medical conditions. So for this sub-competence, level 1 recognizes urgent and emergent medical condition and initiates system protocol as appropriate. Level 2 performs an initial assessment of patients with urgent and emergent condition. Yeah. So level 3, level 4, and level 5. Yeah. So every sub-competencies should be defined. The milestone, ya, level 1, level 2, etc. Nah, ini menjadi dasar untuk menentukan residen itu sampai di milestone yang mana, gitu, ya. Apakah di milestone ini? Jadi misalnya sudah residen tahun pertama, ya, mungkin ada residen A mencapai milestone 4 itu beberapa kali menangani kasus emergency. Tapi ada juga residen sama-sama semesternya sama, tahunnya sama, dia sudah menangani mungkin lebih banyak kasus emergency, tapi levelnya masih level 3 gitu. Karena di dalam OBE itu mengakomodasi kecepatan belajar setiap individu. Makanya di dalam OBE atau KBK ya, Competency-Based Residency Training itu disebut individualized ya, kurikulumnya individualized. Learningnya individualized learning. Jadi nanti setiap presiden punya mapping ini. Ada yang sudah sampai level 4, ada yang masih di level 2, walaupun sama-sama di tahun yang sama ya, di batch yang sama gitu ya. Nah, ini contoh milestone ya, contoh milestone-nya. Nah, ini contoh kompetensinya adalah make informed diagnostic and therapeutic decision that result in optimal clinical judgment. Nah, ini milestone 1-nya ya, first level milestone. Ini milestone 2-nya ya, ini milestone 3, ini milestone 4 ya. Nah, sehingga untuk residen tahun kedua ya, untuk kompetensi tersebut dia di-entrust ya kalau sudah mencapai ini gitu ya. Kalau ini milestone ini sudah tercapai, subkompetensi ini sudah tercapai di level mana, dia baru di-entrust ya, dipercaya untuk melakukan tindakan tersebut gitu. Nah, secara teori ini ketika mau mengembangkan kompetensi base jelas berangkat dari outcome ya. Outcome harus clear, profil kompetensi ya. Kalau kita biasanya pakai istilah sekarang itu area kompetensi, lalu kompetensi, kemudian komponen kompetensi, ya kriteria kinerja minimal gitu kan, yang di KKI sekarang. Tapi intinya itu adalah hierarki ya, hierarki kompetensi. Dan masing-masing ada progresinya yang disebut dengan milestone tadi. Untuk setiap sub kompetensi ada progresinya ya, developmental progressionnya. Nah, kemudian baru sesudah kita buat milestone-nya, kita tetapkan how we are going to teach or how the resident will practice ya milestone tersebut ya, bagaimana proses pembelajarannya. Nah, ini tadi learning experiences must be tailored to learner needs. Nah, ini. Jadi proses belajar tuh bisa individualize, bisa beda-beda ya. Mungkin satu residen dia cepat atau residen yang lain butuh waktu berkali-kali, bahkan butuh latihan dulu, butuh dibimbing lagi gitu. Nah, lalu yang keempat tadi, instruction must be focused on relevant competencies dan learner assessment must follow programmatic approach ya. Tadi Eric Driesen sudah menjelaskan tentang programmatic approach ya. Nah, inilah yang disebut dengan constructive alignment. Ini juga ciri dari competency based residency training atau outcome based adalah adanya alignment antara learning outcomes ya, and learning activities dan juga antara assessment task. Jadi ketiga ini harus align gitu ya, harus align. Nah, ini yang perlu dilakukan ketika mau mengembangkan competency-based residency training. Yang pertama, kompetensi must be clearly defined ya. Jadi kompetensi itu dispesifikan, di-clearkan. Ini selama ini sudah berproses ya di KKI, masing-masing kolegium menyusun standar kompetensi. Nah, lalu yang kedua, there must be sequence developmental progression. Harus ada tadi milestone, sequence ya, dari perkembangan. Nah, the program can use milestone tadi stages dari Dreyfus ya to map desired development. Jadi lalu masing-masing ketika menyusun kurikulumnya, masing-masing komponen kompetensi ya, yang kalau di kita istilahnya komponen kompetensi itu dibuat milestone-nya ya, milestone 1, 2, 3 dan seterusnya ya. Nah, juga kita mendefine zona of proximal development ya, ya. Ini maksudnya tuh gini. Ini dikembangkan oleh Vygotsky. Zona of proximal development tuh intinya bahwa kita memetakan ada bidang-bidang yang sebetulnya residen itu bisa melakukan sendiri tanpa help ya. The student can do without help. Nah, tapi ada juga daerah yang disebut dengan zone of proximal development. The students can do with help. Ya, ada juga daerah yang di sini the students ability mahasiswa atau residen ini terlalu berat untuk melakukan ini ya. Jadi karena itu dalam menyusun milestone maupun subkompetensi kita pilih di daerah sini ya. Kalau jangan yang terlalu mudah dan juga jangan yang terlalu sulit, intinya gitu ya sebetulnya. Nah, kemudian yang ketiga, learning experiences must be tailored to learner needs. Jadi proses belajar disesuaikan dengan kebutuhan individual. Nah, ini ya. Tailoring to individual learning needs implies individualization. Jadi ini ciri yang sangat utama dari KBK atau OBE bahwa proses belajar itu individualize ya. Nah, kemudian jadi setiap presiden tuh punya mapping ini ya. Ini contohnya punyanya si Jones gitu ya. Untuk IPA dia baru mencapai ini ya di tahun pertama. Ini postgraduate year 1, year 2, year 3, year 4 ya. Nah, mungkin temannya mapping ininya beda ya. Mungkin dia IPA-nya dia eh, sudah dia baru nyampe di PG 2 misalnya ya. Eh, apa namanya untuk milestone 2-nya atau milestone 3-nya. Jadi setiap presiden mappingnya bisa beda-beda ya. Nah, kemudian yang keempat, instruction must be focus on relevant kompetensi. Jadi proses belajar sesuai dengan kompetensi dan juga ada feedback ya. Specific feedback should focus on relevant competencies. Nah, tadi sudah disampaikan contoh bagaimana memberi feedback ya oleh Eric Dyson harus sesuai dengan kondisinya ya. Lalu learner assessment must follow a programmatic assessment. Artinya penilaian itu longitudinal ya. Tidak tidak one off ya karena tadi untuk mencapai satu kompetensi untuk bisa melakukan satu IPA dibutuhkan progresi, dibutuhkan tahap-tahap perkembangan ya, nggak bisa kita hanya menilai di satu satu apa titik saja, tapi kita harus lihat progresinya gitu, progresnya makanya menjadi longitudinal ya, asesmennya menjadi longitudinal. Jadi banyak menggunakan elektronik portfolio dan kemudian ada komite yang khusus ngecekin setiap presiden sudah sampai mana milestone-nya tadi, sudah sampai mana dia diberi entrustment ya, diberi APA-nya udah sampai mana. Nah, ini ya the importance of individualized curricula preferable time variable. Jadi kurikulumnya ada, cuma implementasinya tuh bisa individualized. Setiap presiden tuh bisa beda-beda gitu ya. Perjalanannya sesuai dengan speednya masing-masing. Ini tadi learner background itu beda-beda. Learner proficiency dan their learning attitude juga berbeda. Ya, learning opportunities ya, situasi pasien yang ada juga berbeda gitu. Ya, sehingga di dalam competent based residency training memang waktu dilepas. Kalau kita lihat yang Singapura tadi, dia kayaknya masih kombinasi ya, masih hibrid. Karena dia masih pakai rotasi yang berbasis waktu juga tadi ya. Rotasi ini 4 bulan itu. Jadi memang sebagian besar kalau kita lihat di beberapa negara mereka hibrid antara time based dengan kompetensi based ya. Jadi yang benar-benar pure kompetensi based itu belum banyak juga ya, masih piloting di Amerika mungkin yang paling banyak sudah menerapkan. Nah, ini contohnya ada penelitian dari Dorling ternyata ya sama-sama untuk suboccipital craniotomy kalau dengan tradisional ya dengan time base dia butuh waktu sekian, tapi dengan kompetensi base butuh waktu yang lebih cepat ya. Jadi dengan kompetensi base seseorang dinyatakan lulus atau selesai bukan berbasis berapa lama waktu rotasi atau berapa lama, tapi dia diuji udah tadi EPA-nya udah bisa diberikan apa belum? Semua milestone-nya udah tercapai apa belum? Kalau udah bisa lebih cepat. Nah, ini ternyata dengan kompetensi base waktunya bisa lebih cepat ya dibanding dengan yang rotasi gitu. Untuk menguasai satu prosedur tertentu gitu. Demikian yang bisa saya sampaikan, mudah-mudahan bermanfaat. Terima kasih banyak. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih, thank you very much, Prof. Titi. Mohon maaf, ini waktunya kita molor, extended beyond the schedule ya. I think we proceed with the next speaker and then we discuss later. Please, Dr. Ivan, deliver your presentation. Oh. Kak, maaf.
Masih
Masih
mute. Iya.
Ya.
Halo,
Iya.
bisa kedengaran?
Iya,
Ya,
iya.
ya.
Baik, let me just check. Sudah bisa kelihatan, Dr. Ros?
Sudah.
Sudah ya? Okay.
Belum slideshow.
Yeah. So thank you very much again for all the speakers that obviously have been given us a very enlightenment and also eye-widening for all of us to understand more about how we transform our current training program models to somewhat the opportunity to come to a best practice, which eventually what we're hoping to have a more accountable ONG training system. So just to give a little background, obviously everyone here understands more about where we are at the current status of the dire needs of the quantity and also the quality and distribution issue of our doctors' production. And at this present time, we are so lag behind into the number of doctors with the per population ratio. And as you can see down underneath here, we're one of the lowest in the region for doctors and medical professionals, quantity and also the distribution, as you can appreciate that how much of distribution is a big issue for us, particularly in the eastern part of Indonesia. So if you look at the range of the specialists, that's also another additional issue because when we look into OBGYN, for instance, that this is the data that was captured by our Vice Chairman, Dr. Brahmana, who presented the scarcity of the Indonesian specialist distributions, especially in the islands outside of Java and Sumatra. And again, there are a few key issues how we're going to address this. Despite the 5,400 of plus specialists that we have in the country, we have definitely limited number of OBGYN specialists to be able to provide services. But we also have issue of uneven distribution, which obviously we need to acknowledge that the problems with Indonesian maternal health outcomes remains similar, although that we are seeing some improvement, some metrics that we see some improvement. But the key challenge of the lack of resources and especially the distribution is still very much apparent. And if you look at the standardized skills, and we can see that we've been talking about 10 billions of Indonesian rupiahs going out of Indonesia per year, and that somewhat gives us a lack of confidence of our patients, customers, that we need to work harder to ensure that every doctor that is in Indonesia, especially OBGYN, will provide the similar services. And that, of course, would need to be sort of standardized to what the supporting facilities that is available in the hospitals. And that comes to the point of how we're going to provide them with good technology. We provide them with good services where we know there's a lack of movement towards improved reimbursement model. So there are a few ways going forward. Number one, we need to look at the increased equitable distribution, and also we want to focus today on the standardized training competencies. And of course, this is the government, sort of contribution that need to strengthen the facilities, and also the private sectors, how they want to improve the referral. And of course, the BPJS and the national insurance regimen. And eventually we need to monitor. And as we speak at the moment, we do not have any long-term outcome to our neonatal database. How we see that our maternal outcomes, we only just see a very limited numbers of the areas of interest that we obviously have been sort of putting the collection of data over the last few years or so. So just to take an example of several of our colleagues and peers in the regions, you'll see here in Australia and New Zealand, being probably the closest reference of the Western and more developed country, where pretty much, I think, similar to what we have observe and listen to our colleagues from Singapore, that their number of specialists is already close to reaching to 10, which is 8.7 per 100,000 population. So again, they have various of subspecialty areas, and all of the trainees are based in the hospital-based model. To understand more about the context within our Southeast Asia region, we see that we are one of the amongst lowest OBGYN ratio in the, aside from Malaysia, of course, but we definitely have a much bigger problems. The fact that we have islands, which is demographically is quite challenging for our doctors and patients to commute, whereas in Malaysia they only have 2 islands, 2 demographic areas in it's not really something that I would consider apple-to-apple comparison. But if you look at Philippines and Thailand, and even worse, if you look at Japan, we're so far behind in terms of our quantity. So that gives you probably a flavor and color of what actually is our challenge of our quantity, and especially with the current rate of production. So how do we reform such production and distribution specialists and subspecialists in the country? So I think the training model for our doctors are extremely crucial. And of course, we have current challenges in providing supply, and not only for our numbers for us to keep up with our ratio, but also in the same time we also need to acknowledge that the process of the training itself needs to be evaluated, because eventually what we want is the outcome, what Prof. Titi has said, that the competency-based outcome is driven by the actual competency itself, the ability to be able to do the task rather than the ability to pass the exam, which is something that's really crucial. So the first, I think, the addressable issue that we need to highlight is the major deficit and uneven distribution, with the various of indicators that we are very much well aware of, but also at the same time the reformation, the transformation of healthcare that's been supported by legal framework. There may be some obviously adjustment that we need to do, and especially to align with the long-standing specialist training models that we have been adopted to our own ways of being trained as a specialist back in our time. But this needs to address several issues, which I believe that the 3 key issues that we need to address very seriously. Number one, how can we protect the reports that obviously coming into the MDP, which I think is really quite crucial for us to continuously having flow of complaints of our patients. And secondly, we see that in terms of our the model of education is still relatively unaffordable and non-transparent, and it's becoming a major hurdle for us to unlock the capacity of many of our potential candidates. That again, to look at the benchmark that we see what the Singaporean has done in their training model, which is quite mature. I think we have some work to do. We have a long way to go. But I believe with the current status where we do have another hurdle, where how we're going to align between the university-based model and a hospital-based model, which I do not think that we should really be, sort of, so this I guess it's more of a debating in terms of which one is good and which one is bad. But I think at the end of the day, we want to contribute to all the addressable issues that I mentioned before. So I think what we need to address one more time is that how we as the whole organization, the whole institution, and the whole stakeholders in this sort of campaign, we need to address how we're going to improve. Of course, before we want to improve, we need to understand what we are doing at the moment. So just to give everyone on the same page that we have been trained, we are all pretty much sort of very familiar with the university-based training, which takes about 4 to 5 years to complete, and all of them are trained in affiliated teaching hospitals. So the emphasis of academic process and standardized competency achievement has been evolving over time. But again, the level of time based model, which obviously is something that we see that can be adopted into a hybrid model, what we see in various countries like in Singapore, and UK, and Australia, where they see the minimum time requirement is still very much of a reference, but the competency needs to be achieved, and not only by the time that they complete the competency exam, but also to address their level of portfolio and work-based place assessment. And I think that comes down to how the resident or the trainees would comply to all this requirement, which eventually that comes down how we see them as a human being. And again, working hours is really a very important metric to evaluate, and also the payments of how they've been appreciated as a contracted individuals who obviously they contribute into the clinical workload. So at current moment, as we know, the resident have to pay their tuition fees, and unfortunately, not many financial support is sort of provided to many of the candidates that may have good potentials, but with economical challenge that they don't have that access to be able to get the training that they are obviously are entitled to. But again, we only produce approximately about 250 graduates per year of specialists that gone through the national competency exam. And again, only just recently that the hospital-based training model is being introduced. And of course, we need to see that from a fairness, how we're going to complement rather than competing, because I think at the end of the day, we have a similar, I wouldn't say similar, but I think we have the same objective, how to achieve good quality specialists that we can distribute fairly to various places in Indonesia. So this is the model that have been the implementation of the college and the teaching academics from the universities to work together to build this national board exam. And again, this is only one part of what we can objectively measure the competency. But again, the the requirement for these candidates will need to be reevaluated one more time, how they can come up to this level of achievement. Because at the end of the day, the licensing exam or competency exam is only one phase of a person to be recognized of their competency level. But beyond that, we need to ensure by the time that they go into their practice, their competency training throughout the years of their residencies would need to be obviously adopted. So we acknowledge that we have the additional competency training by a subspecialist, another 2 to 3 years of subspecialist training. But because of our lack of sort of institutions that can provide study program for subspecialists, that obviously the limitations of supervisors, trainees, training educators, we still have limited numbers of these subspecialists in the country. However, with most recently the introduction of fellowship, will allow us to have an additional mini subspecialist training program, which again, this is a complete different program to subspecialist, but it can be considered to be part of it. However, this fellowship is destined to cater the area of needs, which again, we need to evaluate how we can increase the numbers. And I'm glad to hear that the last 3 speakers have actually looked into how we can collaborate and link between specialist, fellowship, and also subspecialist training program. The challenges, however, we still, the issues that we stated before remains that a challenging proposition for us with limited resources. The trainees unable to find access to cases, supervisors, good training facilities, and eventually with the high tuition fees, that's still a major burden to how they can be provided with access to proper training, and especially with candidates that have limited financial capacity. So, ladies and gentlemen, so I think to look at the key challenges at the moment, it is clear to say that we have a 3 major, if I may, key challenges that we need to address. Number 1, how we can improve immediately of our supervision level by having specialists that can adopt into the peer-based training model, which obviously that needs to be well certified to recognize such a cohort. And also the limitation of time, that how much of time that the supervisors would allow the case exposure, and also providing feedback, like what the Professor Eric has already shown us the video of how much of effective feedback can be given to trainees that would need certain sort of empowerment to improve their level of proficiencies. The expertise, where a lack of expertise, and I think that comes to the point that where and how we're going to address the current regulation to allow much broader cohort of supervisors to allow training for specialists, fellows, and also subspecialists. And cases is another issue, because obviously when we open up a facility that we claim to be able to train properly, it is not only that we limit ourselves because the fact that we want to open one, but because we need to be responsible enough to allow the institution to provide cases, and the variety of cases from center to center. We need to address that when we come down into the minimum standard of the training facilities. So again, the second challenge that we need to address is well-being monitoring. Of course, we need to address that how the time constraint that we don't want to push someone to push them to become competent when they're not competent just yet. But we do want to acknowledge that the competency level sometimes go parallel with time. So we need to find a way in between to allow these challenges and embed it into our sort of transformation of our spacious training model. Just to reiterate one more time of what Prof. Titi has already said, that drivers and also this is a the slides from a CBME course, that we see that the residency are expected to come to a proficiency level rather than expert. So we have to acknowledge that many of our supervisors are highly expected the trainees to become expert, and that is not the case, because what we want is that we want them to become someone who probably not necessarily novice, but we want to have someone that have some basic knowledge, basic exposure. So it comes back again about where do we screen, where do we recruit, and how do we select our potential candidates for residents. And I think having some experience would help before they embark on starting their first year of training. And then after that, we need to acknowledge that throughout the time of their training, they need to be obviously exposed to cases, and the supervisors need to allocate their time. And as you can see here, the clinical exposure and workplace-based assessment are really, go parallel. And the more, as you can see in the right graph here, that the more cases that one is exposed, then obviously the accuracy of the clinical competency is improved. And I think that really is, tells the story about how we really need to, sort of expose the trainees to get more cases to do. And again, I think being quite pragmatic at the moment, we need to acknowledge that we've been sort of obviously exposed to the current training program that has been really we've been using it for a long time, but we also have to be quite I think realistic as well, that we can see the best practice and some other sort of training program that has been successfully implemented. And again, the well-advanced model like the States, UK, Australia, Singapore, and to acknowledge that we have to look at some other countries like Malaysia and China. I mean, they have a slightly different model of training, but again, most of them, probably all, would actually be looking into the college to really being independent to set the standards, competency, and curriculum as an independent authority. And most of the well-developed system, the residents are paid. And again, in some places where obviously still in developing phase, then they may have a similar sort of model such as ours. But again, it comes down again about how the well-being and the welfare of the residents really look at from how they can live their life, not as a student, but as a clinical trainees. So the accreditation, the exams by the college of the board are not done by the government, and well-regulated working hours. And of course, hospitals, teaching and training hospitals at the training site is something that we need to consider as an employer rather than a part of the academic institutions where we normally would pay. And what we see, what has always happened in those places, that the government works as a funder and regulator, not as a curriculum provider. So I think this is clearly very important to us to address, and how we're going to have these teachers and examiners with experience. And experience comes into not necessarily someone with higher degree, but someone with a similar experience and accredited and certified. And that is a way how we're going to expand our broader sort of cohort group of educators and examiners for our specialist training program. So in my viewpoint, I think we should to look at, we want to be constructive. So I think if you want to look at the left box, I think that's really important. How we can see the three-parted model where we have the college and university to work together to provide curriculum and academic insights, and how to make sure that the knowledge-based education is being properly given to the residents. But where the residents are going to be trained, and this is the focus where the teaching hospital needs to be the main clinical partner, and the government needs to ensure that the process is well funded, and it needs to regulate well, and needs to have a good structure to adapt into the current regulation that we have, to adapt to what we see in other developed countries that have already, obviously established as the best practice. And financing is definitely one issue that we need to, to improve. Resident well-being work hours, and I think that's something that we've seen over time. We're trying to see that the issues of the bullying and all others, and I think that the resident welfare and well-being is really extremely important to keep an eye on. And equity access to distribution, definitely. Once the sustainable financing model is already been implemented, then we can start looking into, developing our quality of education, because the residents are not going to focus on how they live their life, because they need to focus on how they can train themselves. So in that way, we will be able to have an independent college like OBGYN, for instance, to work together with the teaching hospitals, with the university, and also to the government, how we can provide a high quality assurance system that can be easily, sort of reflected into many of the quality assurance system that has been already implemented in places like Singapore and some other places. So, the ladies and gentlemen, I think I would like to, sort of highlight the several, pillars that these slides are obviously very, very, sort of fundamental for us to see where we're going to go in terms of improving areas in accreditation. We need to have a really good, healthy, competitive accreditation to ensure the quality of the accreditation itself is well in place. And the governance in between the academic, regulatory, and also funding roles need to be really quite, and as I said, the three-parted model, and how we see the pillars of improving the construct of the student from the recruitment, the teaching model, and also the examination outcome. And the resources are clearly important, how we can define our competent and certified faculty members and supervisors, which eventually it is our duty to ensure that this process is conducted in very selective ways, but we need to have flexibility of recruiting individuals who have passion, who also have the motivation to become supervisors. And just to also add the facility infrastructure, this is again another very important measure to ensure that what they are trained will be relevant when they have finished their training. And lastly, finance and curriculum, definitely these are the sixth and the seventh pillars that we need to improve. And all of this, I think everyone in the bottom, the college, the hospital, the government, the universities, and the society will need to work together to allow us to have a really honest, positioning that we see ourselves at this point in time, and then what do we see ourselves in the next 5 to 10 years going forward. So, Dr. Hermanto and the attendance of our this afternoon's session, I really am thankful that we have the opportunity to be able to share, and also to learn from our peers and our colleagues from the Netherlands, from Singapore, and from Prof. Titi from Jogja as well, that I think we can do so very well with our process of transforming our teaching and also specialist training program, that again, based on the best practice, we see that the time-based to competency-based, we can do a hybrid model, but I think it's something that we can see is what we are trying to improve. Not looking at from a university and a hospital-based training program, but we see how we can achieve that competency based on their ability to be able to achieve their completion of ability to do the task that they are supposed to do, the EPA, what has been said before. Transforming the educators, specialists needs to train specialists and assess what matters, and the workplace-based assessment is really important. We need to have national accountability, and I think the standardized sort of credibility, working closely with colleagues from Singapore, Malaysia, UK, Australia, some other places, and I think it's very important to have people of confidence about our transformation. And we need to prepare our future leaders, meaning that our trainees, our supervisors, our master clinicians, our clinician scientists, clinical academics, they need to really transform ourselves to become stronger specialist cohort group that eventually will become our backbone of our resources going forward. So with that being said, I think I would like to conclude my afternoon lecture, and hopefully this will give you a better highlights of what we want to achieve going forward. Again, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Dr. Hermanto still mute though.
Mute, yeah. I think it's we have learned so many things. It's only 5 minutes left. So please, if you have question, please give one question, please. No questions from Prof Titi? Untuk Prof Titi, menarik sekali tadi Prof untuk bahwa membedakan individualis learning dan yang selama ini dilakukan seperti prasmanan dan nasi kotak. Ya, jadi kurikulumnya bisa sama tapi setiap orang berbeda-beda. Kemudian Dr. Ivan sini with transforming from within, ada 6, there were 6 suggestions from Dr. Ivan Zini. Maybe Dr. Yesi, is there any questions, Dr. Yesi? Yes. So the transforming from time-based to culture, there are 6 transforming from within suggested by our chairman, and from Dr. Prof. Chitra is a very complicated education process in postgraduate process in Singapore, but I'm impressed by no Ministry of Education and the duration of the OBGYN training in Singapore is 6 years. Yeah, almost the same in Netherlands, also 6 years. Yeah? And from Professor Eric, we learned that vertical integration and that time piece is should change to competency based. That's my summary. I will, if you have no questions, I will deliver this time for Dr. Khairunisa. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Dr. Hermanto. It's really nice and really enlight our perspective about residency program, time-based, competency-based program with their strengths and limitation. Also, thank you very much to our honorable speaker for the time and insightful presentation, also the discussion in this afternoon. And today we have learned that not only about the involving structure of competency-based medical education, but also we learn about the broader responsibility of shaping future specialists who are competent, compassionate, adaptive, and socially accountable. And the time is up. Before we officially end this webinar, I would like to invite all the speakers, moderator, and all the participants to join us to group photo session. Please kindly turn on your camera and look forward to Zoom screen. We will take the several screenshots and give the best smile. We will begin in 3, 2, 1. Okay, thank you very much. And now we have arrived at the end of today's webinar. Thank you for your attention and participation. I'm Dr. Nisa as your MC, and also on behalf Indonesian College of Obstetric and Gynecology and also the committee, sincerely apologize to the shortcoming throughout the event, and stay healthy, stay inspired, and have a pleasant afternoon. And see you at the next webinar. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Terima
kasih Dr. Hermanto, Dr. Nisa,
Ya, siap.
Terima kasih Dr.
Terima kasih
Ivan.
semuanya. Mari Dr. Hermanus.
Terima kasih.
Siap.
Selamat. Luar biasa. Sampai ketemu.
Oke.
Prof. Titi, terima kasih.
Dr. Ivan jangan lupa soal-soal ya.
Siap.
Karena kolegium bikin soal soalnya.
Siap. Dr. Nisa, terima kasih banyak.
Thank you supportnya
Mari.
semua. Jadi
Terima kasih.
Jayapura jalan nanti Mei akhir sudah mulai mereka matrikulasi.
Mantap.
Ya, siap. Sukses.
Baik, saya pamit
Siap.
dulu.
Siap.
Assalamualaikum
Izin
warahmatullahi
live.
wabarakatuh. Mari.
Yo.